Hello, and welcome to the GRACE podcast series. My name is Denise Brock, and I am the Operations Director for the Global Resource for Advancing Cancer Education, or GRACE. In this podcast series, we interview patients, advocates, and healthcare professionals to provide the most updated information for our community and to highlight important issues facing those dealing with a cancer diagnosis. We hope you find this information valuable. For questions or comments, please visit us at cancergrace.org.
In the Pacific trial, the treatment approach was chemo and radiation and then assess for response or progression. And in patients who hadn't had a marked clinical decline and hadn't progressed, would start on Imfinzi, durvalumab immunotherapy within a 6-week window. The trial started by looking for a 2-week window and then had difficulty enrolling patients and broadened it to 6 weeks. And there was a subset analysis that suggested that the patients who started immunotherapy within 2 weeks got more of a benefit from immunotherapy than the patients who started at 3, 4, 5, 6 weeks out. If you have a patient now who is just going through treatment and you're planning what follows, are you getting imaging in less than 2 weeks and planning to start them earlier? Do you think that this is a clinically significant and meaningful difference, or is this an artifact of patients who were able to start within 2 weeks are not the same patients who were able to start within 6 weeks, and we shouldn't necessarily aspire to shoehorn everyone into an earlier start?
Yeah, I mean, I think, again, the numbers are small. The subset analysis does suggest starting earlier could provide a benefit. I think patients are in various places after they finish chemoradiation. Some patients kind of sailed through it and are ready to kind of move on. It means that then they'll be done with their year of therapy sooner. Frankly, most of my patients, especially the ones that I treat at the VA, do have significant side effects, especially towards the end from their chemoradiation, and they do want and need a break. And so this is not data that I would use to kind of push people into getting it sooner if they're not fully recovered from their chemoradiation. And I, would certainly offer it to people who did fine, and especially because we're seeing some suggestion that they may do better, but it's not something that I'm using to push patients who could use a little extra time.
So it hasn't significantly moved up the timing of everything.
No, and in general, I mean, I'll say the Pacific trial, there wasn't a really significant increase in the rate of pneumonitis. But I mean, again, in real world practice, I do worry about that. And especially, I think the patients that I'm treating at the VA, where they do have underlying lung disease, COPD, emphysema, they've just finished chemoradiation, and we're worried about that kind of sort of extra possibility of autoimmune pneumonitis.
And again, pneumonitis is inflammation in the lungs. Correct. That can be caused by many things.
Agreed. And so one of the things that we worry about is the pneumonitis caused by radiation and the pneumonitis potentially caused by the durvalumab Imfinzi, and there being an increased risk because of these two things that could be causing pneumonitis. And I think in real life clinical practice, I have seen this. I've seen patients who are more prone to developing pneumonitis from the radiation just by virtue of having not so great lungs to begin with. And those are the patients that make me very nervous about, starting right away on the durvalumab. So I think it depends on the patient. Again, kind of depends on where they're at after chemoradiation and how aggressive they want to be.
What's your view about the timing issue with, I used to routinely get scans at 3 to 4 weeks out at least, because we know the radiation effect can take that long. But has the Pacific trial and the suggestion of maybe there being more of a benefit early than late change the timing of the scans and start of subsequent treatment for you?
Well, I agree that I think it's hard at a small data set that wasn't designed to answer this question, whether that 2 versus 6 week is a real difference and doesn't have to just do with the patients who happen to make it by 2 weeks. But there is something scientifically, at least in principle, about doing it sooner, with the idea that, what part of the reason we think immunotherapy may work after radiation exposure is radiation has blown that tumor to smithereens, that tumor is circulating in little fragments, it's being processed by the liver and the kidney. The immune system's kind of attuned to it at that time. So there's some sense to doing it as soon as you reasonably can. And I don't want to do it the day after chemo radiation finishes, but I also wouldn't wait a year. I actually would say, no, if it took you a year to recover from chemo radiation, I'm not sure that immunotherapy helps. Where do I actually put my foot down? I don't know, but I do try.
Yeah, there's nothing magical about 6
nothing,
weeks.
Not at all. It's all,
7
we always
weeks
have to
is
choose.
useless.
Exactly.
Yeah.
But, the way I've operationalized it, I've now started getting my first scan about 2 weeks out. I plan to start. If they're not ready, I feel very good about giving, hey, take 2 or 4 weeks off. Let's reassess. And even 2 to 3 months out, I'm comfortable doing. But when I start getting past that, what was it that made them unfit to start this soon? I'm having that conversation with the patient and in my head. But that's at least there is some reason for why I don't want to wait too long after the radiation if I'm going to do this and have it be beneficial.
One of the limiting factors in executing this in practice is concern about pneumonitis, inflammation in the lungs. We should remember that pneumonitis didn't start with immunotherapy, that we know that giving just radiation and sequential chemotherapy, there is a risk of pneumonitis in the 5-ish% range or higher, maybe. And it's about a quarter of patients when you give them concurrently, which is our standard. So this has been a known risk, and it doesn't occur typically during the chemo and radiation, but most commonly weeks to a few months out. So it's in this ambiguous background of knowing there's this looming risk that we are potentially giving immunotherapy. We also know that the chance of pneumonitis is modestly higher, going from about 1 in 4 to more like 1 in 3 patients. So not staggeringly higher, but not the same. I have had at least a couple of patients who have had early pneumonitis developing 3-4 weeks after the chemo and radiation, which is not unprecedented. It's earlier than expected, but sometimes the cancer doesn't read the book. And so I'm interested in your thoughts about, for a patient who has poor pulmonary function just from bad emphysema or crawling to the finish after the chemo and radiation, maybe with the early start of pneumonitis, does that make you especially gun shy about starting durvalumab? Do you have more of a wait and see approach and give them potentially 2 or 3 months to so-called declare themselves as to whether that's going to be a major issue or not?
I certainly do. For those patients who have significant COPD, whose oxygen levels are already in the low 90s, where our normal is usually in the high 90s, those are patients where I'm not going to do the 2-week planned appointment. I'm going to watch them for a month or two and just be very attentive to those changes.
It absolutely makes me nervous, the pneumonitis risk. And yes, I absolutely wouldn't start it right then and there, and would want to follow them with a few more scans, see if that pneumonitis is really evolving radiographically.
Yeah, particularly if, say, you had a scan that suggested the early start of some new markings that look like inflammation in the lungs. Maybe nothing that screams you can't, but enough to raise your concern.
Right. And so I wouldn't necessarily be wanting to get really frequent scans, but these are the patients where you would probably want to get a shorter term interval scan, perhaps at 3 or 4 weeks, to see if it's evolving. And of course, letting patients know if they're developing symptoms. I mean, that's another big thing, is if they're feeling like they're getting more short of breath, more easily, then those are sort of warning signs for me.
Do you have a low threshold for starting steroids in this setting?
I do. Right. I have a low threshold to start steroids, and then again, kind of see if there's symptomatic improvement, and then, schedule a taper thereafter.
Right, because I think it's important to say, because pneumonitis maybe isn't something a lot of people have heard of, except in this context. Pneumonitis can range from something we see on a scan that has no clinical import to something that gets you in the ICU. Like pneumonitis has a broad range. So when we talk about treatment, when there's enough pneumonitis that your oxygen level goes down a couple notches, that you're coughing really significantly, or the scans look bad, we're talking about giving prednisone, a steroid, at high doses, potentially for weeks and months. So, big quality of life hit. So just to frame that in perspective. But I'm watching these folks like a hawk. We teach them what to tell us about between visits. These are all things we're looking out for.
Thank you again for joining us. This podcast was made possible by the generosity of sponsorship from our friends at Lilly, Novartis, Takeda, AstraZeneca, and Exelixis. Please like and follow us on Facebook and Twitter. Send us feedback, share your story, donate and visit us for more information at cancergrace.org. Thank you for listening.